We're here to talk about L5-S1 ALIF in the lateral position. We have a few minutes for some questions if you want to go up to the mic. Anybody have any questions for our speakers? I'll start. How about the three of you guys? What about incision? Where do you place your incisions? I know you kind of showed them, some of you got the chance to see them, but maybe you can just, each of you, briefly talk through your rationale for where you put the incisions and why.
Go ahead. Maybe start down here. I think you can definitely agonize a little too much on where to place that incision. At least in my experience, we've basically, and I think Bill alluded to this in his presentation, but lateral cubitus position, it's a long story, but I always do right side up, and I just make a horizontal incision, maybe about 3 to 4 centimeters, centered over a point between the iliac crest and the lateral border of the rectus. I used to fret about, well, how do we convey to surgeons where do you put the incision rostrally caudally? But if you just basically identify the inguinal band, just come just above that, you'll get there pretty much every time. So you don't have to overthink it, in my opinion.
Dr. Varma?
Yeah, so I typically will just find the ASIS, find the inguinal crease. I'll mark out the centroid of the L5-S1 disc and drop a line direct anterior, and that sort of gives you an angle of space where you can then kind of have your, in my mind, the goalposts of your access point, and then a couple finger breaths down brings you to that trajectory that you want. But those are also how it's just taught. In the end, I take the anesthesia, the stylus from the tube, and just push through the skin and take a lateral and make sure that that's exactly going to get me to where I want. And then I kind of cheat a little bit more anterior because I like to get, in the end, when you're placing the implant, I like to drop my hand parallel and actually put it in directly orthogonally as opposed to trying to bring an oblique implant in. So I just cheat a little bit more anterior, but I think I use that stylus as a final cheat point.
Okay. Dr. Smith?
Yeah, same thing. I mean, just you use your tools. I like to draw a little cartoon of the disc space under fluoro, so I know where it is, and I just basically take that line anteriorly where my incision is going to be. Again, it's going to be lateral to the rectus sheath for sure.
Okay.
Quick question. Last night during our talks, there was a conversation where we were discussing that potential complication rate is about a 3% complication rate in terms of vascular injuries with an anterior ALIF. And I've done a couple where I've done it myself. I've done a couple where I've done a vascular surgeon. I'm curious from the whole panel, one of the concerns that my vascular surgeons, I've used several different vascular surgeons who've always been concerned about the same thing. One, what Dr. Varma alludes to, which is that there's a pretty common degree of variation in terms of vascular anatomy. It's rare, it's actually relatively common. And my vascular surgeons have all had experience where the upside is easy. Their concern is when if there's a problem in the downside and accessing or trying to do a repair, if there's some type of vascular abnormality and you have a bleed in the downside that they can't access it. So my vascular surgeons all seem to tell me the same thing. They say it's a great procedure and a great option, especially in obese patients because everything falls away so you have easy access. But from a complication rate, if they get into a problem, either a bleeding which is to the extreme of the wound or specifically bleeding on the downside, that it can be catastrophic. And so I'm curious from the panel, what would you say in terms of the increase in risk of trying to repair a bleeder on the downside versus one which is directly in the wound or even on the upside?
Yeah, I mean, I'm not sure I completely agree with you. I think that the upside is the more challenging area. I think the only way to really injure that lower area is if you really kind of screw up and maybe you thrust your disc space preparation tools on that lower side and go through the annulus. I think that would be a disaster. I think venous bleeding from a supine ALIF is a disaster at times. And the key is, get a little venous bleeding, stop. Don't start manipulating, because once you start tearing a vein, you're in big trouble. And I find that, if you have to lengthen the incision on these cases in an emergency, it's not a big deal. And it ends up being the exact same approach. And I suppose that if you're worried about that downside, you could rotate the patient, airplane the patient away from me, and I think you'd have very good access. So, as I mentioned, I like to have that laparoscopic Liga clip because it rotates and where the clips orientate are very, very easy. And I find certainly to try to suture a vein whether it's getting supine or lateral through a small incision, it's challenging. If you really have to do something to the vein, you just can't pack it off. A ligament clip, I think, is a much safer tool than trying to suture a vein.
Okay. Question at the mic.
Puri Hosseini from San Diego Spine Foundation. I've got a question for the entire panel about the perivascular fat pad anatomy. Is there any established cutoff point in terms of the thickness of this fat pad to name that major vessel mobile, non-mobile, or difficult to mobilize?
I don't think, number one, I don't think it exists in terms of, I've seen a paper or someone sort of give their opinion about that. I think in terms of whether it's mobile, you can safely mobilize it or not, there's so many factors that go into that I think that just the absence or presence of it, I don't think of that as like binary in terms of we can do it or we can't. I think it's definitely binary in terms of is there one or isn't there one, as one of the things that you throw into your thought process when you're really thinking about the operation and whether you can, it's going to be easy, it's going to be harder, et cetera.
Thank you.
Good morning. I have two questions. One is, whenever you are doing your lateral A-lift, how do you go by cutting the contralateral annulus if you are planning to put like a 20 or 30 degree cage? And the second question is that have you noticed any difference in your complication rate for retrograde ejaculation when you're doing your lateral A-lift?
So you're talking about the downside annulus, right? On the downside? Okay.
I'm sorry, what was the
If you're going to do like a wide annulotomy on the disc, like 270 degree
like
decompression, how do you get that downside annulus?
Yeah, I mean, so really the downside annulus is the easier one, I think, especially because I put the left side up. Again, we're seeing already variance in techniques. But I find that if, in most cases, unless they have something very unusual, I can slip that retractor, that downside retractor, under the vein, under the plexus, and almost go to the foramen. And that really makes me safe and protected. And in fact, you'll see that there's actually usually a space between the retractor and the vertebral body down on that downside by a millimeter or two. So that, I think it's safe. Again, to me, it's the upper side. For getting that vein over, I always have a little bit more trouble getting that as far out, laterally and posteriorly as I do on the opposite side.
I think from a left side approach, I have two kind of combating thoughts. One is that it was traditionally taught to me not to release all the way across to the down right side, because since you're kind of working at a semi-oblique angle from up to down, the more you're worried about driving your trials and your implants and everything too far down. So it kind of acts as a restraint. So it was said, just kind of release to maybe midline or a little past, and then with time it's going to attenuate as you work the disc space and put trials in and such. On the other hand, I do find that if it's not open wide enough, then the trials, et cetera, you're kind of putting them in under too much force to try and gradually attenuate or you're trying to rupture it. So I think I agree. I think I would put the retractor all the way around and under direct visualization. I think if you just release it, you can do it safely because you've seen that you've swept everything out of the way. But you still have to be cognizant of not, now that you've opened the downside, that you don't want to drive everything too far across to the down right side from a left approach.
And just again, realize what you're trying to achieve is a patient with degenerative disc disease, and you're not really trying to do a sagittal rebalancing. There's probably no need to release it. If you're doing a sagittal rebalancing, especially an older person, it's probably more important to do so you don't damage the implants as you try to get a lordotic implant in. So you don't have to do it every time. Depends on what the patient presentation is.
And you take what the patient gives you too. I mean, just like in a supine A-lift, sometimes you just can't mobilize the vessels and you just can't get as far around as you'd like to. But I found, to be completely frank, I don't devote too much thought to that contralaterally unless I found that if I can just release the ALL, get as far across as I safely can with sequential trialing and carefully dilating the disc space, I'm usually very happy with the amount of correction I get. To be fair, I'm not putting 30-degree cages in, but we have frequently put in 20 degrees. That's not the norm, but still you can. Typically in my practice, I'm trying to maximize foraminal height restoration as well versus sagittal correction. But you just take what the patient gives you, and you'd be surprised at what you can achieve.
So quick yes, no, retrograde ejaculation.
I think it's going to be a concern. I think we are going to see it.
Okay.
Again, it's like everything else. Like I mentioned, my quick slide, avoid BMP, be careful of electrocautery,
Yep.
lots of blunt dissection.
Okay. I think we have time for maybe one or two more brief questions. I think we have a break. We're cutting into your coffee time. I know how that feels.
Martin Bauer from Lucerne, Switzerland. Thanks a lot for these great cases you were operating on, Bill and Dr. Thomas. These cases of spondylolisthesis and collapsed discs, where you have treated in 59 or 90 minutes. I'm wondering, I wouldn't have done this, I wouldn't trust to do it without a posterior decompression. So with your posterior release you are doing and the facetectomy, did you decompress the nerve root 5 as well?
I mean, from a single, when you start to do more and more single position surgery, you will push the envelope more and more on what you'll try to get away with indirect decompression. I rarely ever do direct decompression now. I just counsel the patient. My failure rate's about 5%, but I just don't. And I think if I try to flip a patient prone now in my OR, my staff has a mutiny. They could just get so upset with me. So you will. I continue to be amazed at what indirect decompression will achieve.
I will do a posterior decompression to release the nerves, central canal stenosis, facet arthropathy very frequently. And I like to see the nerves. Now, the other thing that we really haven't mentioned, I think is very critical for deformity cases. How many of you guys have put hyperlorotic implants and you impact them in and you see end plate damage because you haven't done a posterior release? Single position surgery, you can do your posterior release, then do your ALL release, and when you put that 20 or 30 degree hyperlorotic implant, it goes in like butter. I mean, really, there's no stress on that anterior release. So think about that, especially in these elderly degenerative scoliosis case with sagittal deformities. I think it's really going to add what we can do in deformity work.
Okay.
Because it was a rule for us not to do without decompression from posterior if you have a lytic lesion. So all these scars from posterior. But okay, I take this at home.
Yeah, absolutely. Thank you.
New data, new procedures, I guess. Okay, one last question, and then
Okay,
we'll go to
quick
break.
question for the panel. Especially in young male, sometimes in supine ALIF, we decide to approach by the right to avoid complications as retrograde ejaculation. My question is, in a lateral ALIF, is it possible to achieve, have you done this, to approach from the right, considering that the anatomy of the right iliac common vein would be more favorable than the left against gravity?
I do all my cases from the right.
Okay.
All my cases from the right, and honestly, it's just it's more favorable with my room setup, and that's just the way I'm used to now, and it works fine. My access surgeon works with a lot of surgeons who are doing oblique approaches and lateral ALIFs, and he does left side, right side. Doesn't matter to him. For 5-1, it doesn't matter. But I have heard that somebody else told me about a paper for retrograde ejaculation. Maybe you guys can educate me, but that they showed that it was clearly safer in terms of retrograde ejaculation from the right side versus the left.
Yeah,
I haven't seen it yet, but I've heard about this paper.
Yeah, but is it easier in terms of vein anatomy?
No,
What do you
I
guys
think it's dealer's choice to a degree, as long as you do your preoperative planning. Either yourself or your access surgeon, if you have one, really looks at this. I'd say the majority of my practice when I'm doing this now, this oblique ALIF, I'm doing an EXIF with it. So I don't want to have the patient set up for that. In my team, when I do a right-sided EXIF, they start to panic because that's just what they're used to. So I tend to do a left one over 90% of the time.
I do everything from the left just because I do obliques above, and you do them all from the left, and I'm really using this to try and build a platform for multi-level. So I do 5-1 from the left every time and continue up from there.
I have actually one question for the audience here. Turnover times. How many of you estimate your turnover time is between 0 and 15 minutes?
0 to 15 minutes?
Flip. Sorry, apologize. Flip time, 0 to 15 minutes. 1.5, quarter of an hour.
I guess
Okay,
you have to
15
be
to-
you have to be specific in how you quantify that, though. It's like what exactly is it? Actual?
Yeah, let's say so.
Right.
Closure.
Last stitch.
Yeah,
Last
your
stitch to incision.
Your last monocryl or whatever till the time you're putting in, making an incision for your perk screw.
Yeah.
Okay.
How is
15 to
it
30 minutes. 30 to 45. Okay, so the median somewhere between, you know, those middle two quartiles, and then 45 and above.
Depends.
Yeah, right.
I think we should have.
I'd have to raise my hand on certain occasions.
We need to have a panel discussion for the 0 to 15 minute people.
Yeah,
to
right.
Come up here and
You guys are
tell
giving the
me how to
talk
do it.
next year. Thank you very much. Thank you to our panelists.